Okay. Okay, so afternoon friends, I'm Dr. Sushant Soni. I'm from AIMS Delhi and I'm your pathology faculty with the institute DBMCI. So let us start with the vibe pathology session. Firstly, I know you guys are studying hard for the past 3 days. You're having back-to-back classes. Still, these 2.5 hours, I want your attention to be at its peak. We will, and see, pathology is one of the most important rank deciding subjects, especially in the AIMS paper, firstly. Next, in AIMS, around 20 to 22 questions come from pathology, out of which 10 to 12 are image based questions. So we will be trying in particular to cover as many images as possible in these 2.5 hours. I like this to be an interactive session in the sense that I'll be projecting an image. I want majority of you to WhatsApp me. This is my WhatsApp number. I want majority of you to WhatsApp me the answer to it as fast as possible so that I can go to the next one. So starting with pathology and starting with our first question, that is diagnosis. Before I go further, deliberately I have put majority of the slides as no history slides. In all the live classes I take, I never believe in giving history to the questions. Be unbiased in images. First see the structure, then the organ, then the disease. As you can clearly make out, this is kidney showing the presence of numerous cysts which are localized to the medulla. So grossly it shows me cysts which are localized to medulla, So diagnosis, medullary sponge disease. So firstly, I can divide cystic diseases of the kidney into three main categories. I can divide the cystic diseases of kidney into three categories, that is the polycystic kidney diseases PKD, the medullary cystic diseases, and the last is acquired or dialysis associated. Or dialysis associated cystic diseases of the kidney. First point. Next, polycystic kidney diseases are of two types, that is the adult polycystic kidney disease, adult PKD, and the childhood PKD. Next, medullary cystic diseases are again of two types, that is medullary sponge disease and nephronophthisis. Medullary sponge disease and nephronophthisis. I'm sorry. And the last is acquired or dialysis associated. Next point. Out of these, the main image based questions or gross that can come is from adult PKD, childhood, and the medullary sponge disease. Medullary sponge disease is a good disease to have. If it is a good disease to have, then will it be progressive or non-progressive? It is a non-progressive renal disease with cysts which are localized to the medulla. This is medullary sponge disease. Next point, this gets us to adult versus childhood polycystic kidney disease. Let us see the main gross differences between adult versus childhood PKD. Adult PKD versus childhood PKD. First point, grossly, which will be more enlarged? Adult kidney is larger than childhood, so adult PKD is more enlarged as compared to the childhood PKD, which is just enlarged as compared to normal. First point. Next, outer surface of the kidney. Extremely important to make a diagnosis. Adult PKD has a bosselated outer surface. These are the bossellations versus the smooth outer surface of childhood PKD. Next, cysts. In adult PKD, the cysts, they are randomly distributed in cortex and medulla. Versus childhood PKD, where the cysts, they are present at right angles. to renal capsule. The cysts, they are present at right angles to the renal capsule. This is adult versus childhood PKD. So let us see what it looks like grossly. Starting with the first image, what I am able to see is it is a massively enlarged kidney showing numerous cysts with presence of a bossylated outer surface. All these are the bossylations. On cut section, the cysts are randomly distributed in both cortex and medulla. So diagnosis, adult polycystic kidney disease, adult PKD versus the smooth outer surface of the kidney with presence of cysts at right angles to the renal capsule, with cysts at right angles to the renal capsule. That is childhood PKD. That is childhood PKD. Next point. So these were the gross images. Now let us start with one of the toughest topics in systemic pathology, that is kidney. See, the microscopy is unbiased. Structure, organ, disease. Now I am sure all of you are able to make out that this is a glomerulus. All of you have the WhatsApp, my WhatsApp number. Those of you who joined late, I am writing it again: 9958 450 600. Guys, put it on WhatsApp and start telling me the diagnosis. What do you think is this? Firstly, all of you are able to make out that this is a glomerulus in which capillaries have a nice open patent lumen. Now starting with the first one that I got, 4541 FSGS. Nahi bache, for FSGS you need to see sclerosis. There is no sclerosis here. Next, MCD. No, not at all. What is MCD? Minimal change disease. What is this technique? Light microscopy. Can I ever make a diagnosis of minimal change disease on light microscopy? No, I cannot. For MCD, I need electron microscopy. Light microscopy of MCD is unremarkable. So, irrespective of the image, I will never mark an answer as MCD. Next, what we see here is the presence of capillaries, capillaries have a nice open patent lumen and they are well spread apart in the whole glomerulus. This is a nice normal glomerulus. Next, I have 8877 telling me the answer to question number 2. Nahi bache, do not go to the next question. See the image which is there projected. In the questions, you have just, I guess, around 60 questions, but I will be showing you close to 150 images. So concentrate on what is being shown to you on the slide. This is a nice normal glomerulus. Next, differentiated from the second image. This again is a glomerulus. How do I know this is a glomerulus? Because it shows the presence of various capillary loops with renal tubule on the side. So organ, kidney. Diagnosis: normal, abnormal, abnormal. What is the problem here? Problem is that the capillaries are aggregated together to form lobules. Capillaries are aggregated together to form lobules. This is called as accentuation of lobular architecture. This is called as accentuation. Accentuation means increase. Accentuation of lobular architecture. I have 6-7 answers, that is 9061, 6806, 787 telling me as MGN. Nahi bache, accentuation of lobular architecture. Diagnosis: MPGN, membranoproliferative glomerulonephritis. MPGN is a proliferative glomerulonephritis. MGN is non-proliferative in nature. Here there is an accentuation of lobular architecture, MPGN. 5554, bache, you have told me the answer as A. We are not doing question number 2. I am again stressing this. The image and what is given to you and what is being shown are different. I will show you numerous other images in addition to what is printed. So please concentrate on what is being projected. Diagnosis: MPGN. Next, let us see 1-2 points about MPGN. The diagnostic hallmark: light microscopy. In light microscopy, the diagnostic hallmark of MPGN is basket weave. Is the double contour or tram track appearance. Diagnostic hallmark of MPGN is double contour or tram track appearance, arising because of splitting of basement membrane, arising because of splitting of basement membrane. What is the stain of choice for MPGN? Which stain is most specific for basement membrane? SM, silver methenamine. So stain of choice for MPGN, SM, silver methenamine. Next point, this gets us to our next important topic, that is sites of antigen antibody complex deposits. You very well again know, Acha, before I go further, in today's vibe session I will just be targeting what is important for our mains. So I am again obviously not going from the basics. I expect you to know up to this level and I am building upon that. So you know that there are four main sites of antigen antibody complex deposits, which are subendothelial, anti-GBM, subepithelial, and mesangial. These are the sites of antigen antibody complex deposits. Starting with the diseases, PSGN 1 2 3 4. You can simply message me 1 2 3 4 fatafat say. I want more people to message. PSGN, site of deposit, subepithelial. Next point, what is the special name of deposit with PSGN? PSGN is post streptococcal, it's not subendothelial bache, subepithelial. What is the special name of deposit in PSGN? Humps. Next, MGN is subepithelial in nature versus MPGN, which is subendothelial in nature. Easy to remember, MGN is a 3 alphabet word, it is lean, thin and fit, it crosses the GBM, subepithelial, versus MPGN जो मोटू है, it is not able to cross the GBM, subendothelial. The special name of deposit with MGN is spikes. Next, MPGN is of three main types, but the most common deposit seen in MPGN is subendothelial. Next, with anti-GBM deposit, only one disease comes to our mind, that is Goodpasture's syndrome. Next, mesangial deposits. Mesangial deposits are associated with IgA nephropathy, also called as Buerger's disease. IgA nephropathy, also called as Buerger's disease, and HSP. HSP is Hinoch-Schönlein purpura. IgA nephropathy and HSP. Next, coming to lupus. The initial site of deposit in lupus, I am writing it on the top, that is class 1 and class 2 lupus is mesangial in nature. Next, class 3 and 4 are subendothelial, with microscopy of class 4 showing wire loop lesions. Class 4 lupus microscopically showing us wire loop lesions, whereas class 5 lupus is subepithelial in nature. Class 5 lupus is subepithelial. This again is an important table, sites of antigen antibody complex deposits. There were 4 sites of deposits, subendothelial, anti-GBM, subepithelial, mesangial. Which is the best technique to see the site of antigen antibody complex deposit? Best technique? Answer, electron microscopy. We can see it even by the presence of immunofluorescence. Immunofluorescence is okay, but by immunofluorescence I will not always be able to differentiate subendothelial from subepithelial. The investigation of choice is electron microscopy. Next, so let us start with more images in kidney only. Diagnosis. Fatafat bache, everybody, these images are spotters now. Diagnosis. The minute you see this, you are able to make out, yes, I have numerous right answers. PSG and 806 is wrong bache. Rest majority of you are right. This is a diffuse linear deposit. इससे linear क्या होगा? Diffuse linear deposit, Goodpasture's syndrome. That is anti-GBM deposit, Goodpasture's syndrome. Next, when you see this, remember Iron Man 3. I am a huge Robert Downey Jr. fan. So remember when the villain shows the brain to the girl, this is what it looks like. No, it's not PSGN, not at all. 0217, I guess this is your first wrong answer. Others, FSGS is a blunder. 9061, nahi bache. FSGS is focal segmental glomerulosclerosis. In sclerosis, antigen antibody complexes get entrapped in it. As a result, FSGS is non-specific. We will, irrespective of the immunofluorescence that is given, you will never mark the answer as FSGS. Next, 64541. Bache, you are telling me different slides have been given. Just have a look at the slides. This 2.5 hours of session with me, it is not only to see these 60 slides. I am going to show you around 150. I guess you entered slightly late. 541. I'll tell you in the end what to do regarding the slides. These 2.5 hours, just concentrate with me and try to answer as much as possible. Now I have started getting right answers. The answer is MGN. Have a look at this. This is what the deposit, immunofluorescence of MGN, membranous glomerulonephritis, looks like. Next, diagnosis. This is again, I'm telling you, renal immunofluorescence diagnosis. Agreed. Now, many people are already right in this. You are able to see the presence of mesangial or interspersed deposits. We have already seen that mesangial deposit, IgA nephropathy. It is not continuous in nature. It is interspersed deposit. Mesangial cells are present, interspersed. Next, diagnosis. This is the question number 2 in your printed question, diagnosis. Now, when I see this, I am able to make out that this is the glomerulus. This is the glomerulus with renal tubule on the side. Diagnosis, agreed. I have around 3-4 right answers. What is happening here is the capillaries, the lumen is lost. So, microscopically, this is showing us endocapillary hypercellularity. This shows us endocapillary hypercellularity. The endothelial cells have become hypercellular. As a result, there is a loss in lumen of the capillaries, followed by, look at all these cells. You are even able to make out the lobes of the neutrophils also. All these which I am pointing with my arrow, all these are neutrophils with presence of neutrophilic infiltration. Endocapillary hypercellularity with neutrophilic infiltration. Diagnosis, PSGN. Majority of you were right in this. Diagnosis, PSGN. Next, what is the immunofluorescence picture in PSGN? It shows the classical lumpy, bumpy granular deposits. PSGN, lumpy, bumpy granular deposits, giving it the classical starry sky appearance. This lumpy bumpy description, it's not my way of describing it. I'll never do it in such a sexy and a nice way. This is how WHO describes PSG and immunofluorescence, giving it the classical starry sky appearance. So what we see here is, at some places it is singly scattered, but in majority they are aggregated together to form lumpy bumpy deposits. Starry sky appearance, PSGN. 06806, which it's a very good question. He has asked me how to differentiate PSGN from mesangial deposit of IgA nephropathy. See, when you see this, the singly scattered are less, there are more lumpy bumpy aggregates, and the glomerulus is almost full. Versus IgA nephropathy, images is about differentiation. Versus IgA nephropathy, the mesangial deposits, which are much less as compared to PSGN. Mesangial cells are present interspersed, they are more singly scattered, versus PSGN, which was lumpy bumpy granular deposits. It's not the same, bache. It's not the same. This is PSGN. Have a look at this again. Next, diagnosis. Question number 3. What you see here is the presence of decoy cells. See, the question that was urine examination with these cells. Now, the minute you see the presence of these, they do not look malignant. They are enlarged. The nucleus size is enlarged, but they do not, the nuclei is not prominent. They don't look dirty enough to be a urothelial malignancy. These are the decoy cells. These are decoy cells with presence of enlarged nucleus. And few having, like this one, few having intranuclear inclusions also. fused, showing the presence of intranuclear inclusions also. Next point, what is the significance of decoy cells? Decoy cells, they are used as a marker of polyomavirus BK induced nephropathy. They are a marker of polyomavirus. They are a marker of polyomavirus BK induced nephropathy. Has to be remembered, very right, which is used in renal transplant recipients, which is for renal rejection in the renal transplant recipients. Totally agreed. So this is decoy cells. Next, the other options in this were RBCs and WBCs. So just to show you, the minute you see such a structure in urine, this is the classical RBC cast. You have the presence of RBCs, round cells, RBCs, which are almost red in color, RBC casts associated with a variety of diseases, that is glomerulonephritis, renal infarction, lupus nephritis, good pastures, CHF, pyelonephritis, renal vein thrombosis, and malignant hypertension. So much more important than remembering the list is the fact that RBC casts are non-specific or non-diagnostic in nature. RBC casts, they are non-specific or non-diagnostic in nature because they are seen in a variety of diseases. Versus WBC casts, see this, again you are able to appreciate even the lobes of the neutrophils. You are able to make out that these are the neutrophils with few interspersed lymphocytes, that is WBC casts, which are predominantly associated with interstitial nephritis and pyelonephritis. So this is RBC versus WBC casts. Next, diagnosis. This was question 4 in your paper, diagnosis. Now this is a spotter. I have numerous right answers but few wrong ones also. I do not know bache why you are calling it as MGN. FSGS is a blunder. See, 98902, the minute you say something as FSGS, you should be able to see sclerosis. There is no sclerosis here. What you have is the first slide is normal. Electron microscopy do not get into the nitty-gritties that what is the structure, what is that. Arrow was placed on the foot processes, whereas in the second there is effacement of foot processes which were elongated in the first one, they are effaced. So diffuse effacement of foot processes of podocytes, diagnosis MCD, minimal change disease. Next, diagnosis, question number 5 in your paper, diagnosis. I will be pretty impressed if you tell me this. ABCD, question number 5. Question 5. No, I am still waiting for the right answer. I have the first right answer. Yes. Okay. I am getting the right answers. Agreed. ठीक है. Majority were wrong. I have 4 right answers. बच्चे, this is not Councilman Mallory line. 5411187. Agreed. Okay, my numbers went down, but I had around 4 to 5 right answers in this. This is alpha 1 antitrypsin deficiency. Majority of you were wrong in this. Close to 90% students told me the answer either as Councilman, Mallory line, or ground glass was very few. Majority told me Councilman or Mallory line. देखो बच्चे, before I come to this slide, let us start with the basics in liver. What you see here is the presence of hepatocytes. All these are the hepatocytes which have a nice abundant cytoplasm, granular in nature with a large central nucleus. Diagnosis, this is easy. What you see here is the presence of is it smaller or a larger cell? This is a smaller contracted hepatocyte. We have a clear white space around this also. So what this is an apoptotic hepatocyte called as Councilman bodies. Now next, diagnosis. First identify liver by the presence of hepatocytes. All these are the normal hepatocytes showing granular cytoplasm. What is abnormal here are these two cells in which the granularity is lost. ground glass hepatocytes. So we have seen the first two, that is Councilman bodies and ground glass hepatocytes. I need not even ask you this. Ground glass hepatocytes are most commonly associated with which hepatitis? Most commonly with chronic HBV. Agreed. Chronic HBV. The important word along with HBV is also the fact that it is chronic in nature. Next, diagnosis. This again is a good slide. I am giving you the options. Just tell me 1, 2, 3, 4. First, I hope everybody has recognized liver by the presence of these hepatocytes. Your options are your 1,448. You told me very specifically as hepatitis C virus. How, bache? How do you know that this is, forget chronic hepatitis, how do you know that this is HCV? Not at all. Never ever overdiagnose. Your options are chronic hepatitis, autoimmune hepatitis, cirrhosis, or HCC. Cirrhosis or HCC. 6806, which you told me interface hepatitis and chronic hepatitis. Interface and stuff were the words used in previous classification, not now. 3111, 5298, all the messages, I mean I'm getting numerous ones. The first right answer is 732, 81732, but you are the only right answer till now. Except you, everybody else has told me the answer as autoimmune hepatitis. No. Firstly, I am glad. Okay, tell me the next answer. No, now you have gone to cirrhosis. Nahi bache. Wait, let me explain this. What you are able to see is the presence of hepatocytes. All these are the hepatocytes making the organ as liver. Which is the problematic area? This is the problematic area. Is this cancer? Not at all, because hepatocytes have a normal nucleus. HCC would have abnormal nuclear features, so HCC is absolutely out. Cirrhosis would show the presence of large fibrotic septa. You are not able to appreciate fibrosis in this, so cirrhosis is also out. You only had two DDs, chronic hepatitis versus autoimmune. The inflammatory infiltrate that you see here is predominantly by the small lymphocytes. These are small cells, small lymphocytes, making the diagnosis as chronic hepatitis. Versus autoimmune hepatitis, in which first you know it is liver because of the presence of hepatocytes. These are all the hepatocytes on the left side of the image. Now look at the cells I am showing with the arrow. Large cells, identifying these cells is important. Please have a good look at this. Large cells, abundant cytoplasm, eccentric nucleus. All these are the plasma cells. This has been asked twice. Only two images have been repeated twice, one of which is the presence of plasma cells. Plasma cells in liver is suggestive of autoimmune hepatitis. Plasma cells in stomach, suggestive of H. pylori. Plasma cells in endometrium, chronic endometritis. Bone marrow, multiple myeloma. Plasma cells, 4 organs, 4 diseases. I'll repeat: liver, autoimmune hepatitis; stomach, H. pylori; endometrium, chronic endometritis; bone marrow, multiple myeloma. Irrespective of the location, this is what a plasma cell looks like versus a lymphocyte, which is much smaller in nature. Next, now come to this image, which was the controversial one in which majority of you went wrong. Firstly, this is not the usual stain. Dekho bache, this was HND. Look at the hepatocytes. They appear pink in color with a blue cytoplasm. This is HE, hematoxylin and eosin, versus this slide, which has a bluish tinge in the whole slide. That means this is not HE, this is PAS, periodic acid Schiff, showing the presence of PAS positive intracytoplasmic globules in hepatocytes. PAS positive intracytoplasmic globules in hepatocytes, making the diagnosis as alpha-1 antitrypsin deficiency. This was an important slide and can very well be asked in the future paper. Even if you did not know this, but you had to know that it is not A, B or C. So the answer is alpha-1. Next, this is how we lose a rank in the exam. Next, diagnosis. I am again sure all of you are able to make out these as the presence of hepatocytes. Agrees. Which show the presence of intracytoplasmic eosinophilic inclusions, that is Mallory-Hyaline bodies. Mallory-Hyaline bodies. Mallory-Hyaline, they are composed of, this is question number 6. Mallory-Hyaline, they are composed of cytokeratins 8 and 18. Next, this gets us to our next question, that is, we are done with question 7. Question 7 was autoimmune hepatitis. This gets us to question number 8. This gets us to 2883 plasma cells in endometrium, chronic endometritis. Question 8. Which chromosome is this? Now, what you see here is the presence of golden brown pigment, hemochromatosis, golden brown pigment in the hepatocytes, making the diagnosis, making the most probable diagnosis as hemochromatosis, which is associated most commonly with HFE gene mutation, which is associated most commonly with HFE gene mutation present on chromosome 6. Present on chromosome 6. Long arm, short arm? Chromosome 6 is okay. Long arm, short arm? Short arm. P for petite. Chromosome 6p. I'll write it on the side. Chromosome 6p. Short arm of chromosome 6. Hemochromatosis. Next. Now have a look at this. No history slide, nothing is given to you. You are able to make out the presence of hepatocytes. In the hepatocytes, lot of blue thing is getting deposited. Means it is a special stain. Which stain is this? Prussian blue or the Pearl stain, which is staining iron. Nahi bache, this is not CVC, this is nothing like that. This is the Pearl's stain, Prussian blue or the Pearl stain. Please do not think of this as venous congestion. खुद सोचो यार, venous congestion would be darker, it would be red. This is blue. Plus the hepatocytes have a different tinge to it. It is not HE. This is Prussian blue or the Pearl stain, which is again used for iron, hemochromatosis. This is the same slide. In this one, the golden brown pigment has been identified by Prussian blue staining. Next, question number 9, diagnosis. This is a spotter, and I guess everybody to be right in this. Perfect. I have numerous right answers. Gave gastric antral vascular ectasia. Interspersed in between, we have the erythematous areas. These are the erythematous areas, which gastric antral vascular ectasia, giving it the classical gross appearance of watermelon stomach. Giving it the classical gross of watermelon stomach. Next, diagnosis. Again a spotter, diagnosis. Fadafat se, I want more people to tell me. Diagnosis. You cannot say B. 8890 bache, this is not question number 10, this is a different slide. 65785, now I have started getting right answers. Agreed. See, once what you see here is brown color, light brown, dark brown. Which is the pathological area? The dark brown, where you see the presence of small bacilli in the mucus. Agreed. So this is the silver stain, Warden-Starry stain for H. pylori. So those of you who are telling me the answer is ABC, which wo garbad ho gaya, because this is not the, this image is not printed. This is the Warden-Starry stain, H. pylori. Next, a very important image. I want majority of you to be right in this. No ABCDs, this has not been printed in the paper. Diagnosis. Okay, I have the first right answer, 25806. You are the first right one. It's not celiac. No, celiac disease will show flattening of villi with crypt hyperplasia. So the total thickness is maintained. This is not celiac. Dekho, be unbiased. There are two areas in this slide, one on the top, one on the bottom. Where is the problem? On top or bottom? Problem is in the bottom area, which is showing the presence of large cells with large pink granules in the cytoplasm. So what are they? The slide has a bluish tinge to it. So which stain is this? Pass. So it shows pass positive diastase resistant granules. Pass positive diastase resistant granules. This is not maltoma at all. Please, maltoma will have lymphoid cells. Pass positive diastase resistant granules in macrophages, and the most common location of these macrophages is lamina propria. So diagnosis, Whipple's disease. Diagnosis, Whipple's. This is an extremely important slide. You see, problem was in the lower area. This is the thought process that I want you to have, and the names. Much more important is, and what will get you selected is your thought process. So Whipple's disease. Next, this is the classical feature. The diagnosis itself is written on the bottom. What you have here is the arborizing Christmas tree appearance, Peutz-Jeghers syndrome, PJ syndrome or Peutz-Jeghers syndrome, giving it, or Peutz-Jeghers polyp, fair enough, giving it the classical Christmas tree appearance, Peutz-Jeghers. Next, which mutation is seen in this? Answer. In the paper, when you get the question, it will simply be which mutation. Okay, let me give you options. KRAS, WNT, STK11, MUTYH, or E-cadherin. 5 options, 1, 2, 3, 4, 5. I have one right answer. No, 2 right answers. No, now I have started getting right ones. Majority are still wrong. Nahi bache, it's not STK11. STK11 mutation is with Peutz-Jeghers. This is not Peutz-Jeghers. This was Peutz-Jeghers. This mutation is STK11. WNT, MUTYH. Nahi, garbad ho gaya. Dekho. The first thing you should have thought in this is KRAS and WNT mutations occur in the same adenoma carcinoma pathway. So irrespective of the image, even if I was not given the image, these 2 answers are out. MUTYH mutation is associated with MSI pathway. MSI is microsatellite instability pathway. STK11 was Peutz-Jeghers syndrome, so this is not a Peutz-Jeghers polyp at all. We just had a confusion between MUTYH or E-cadherin. E-cadherin mutation was associated with signet ring cell carcinoma, GIT. In this slide, where is the problem? On the top or bottom? Problem is in the bottom, showing the presence of all these are the signet ring shaped cells with nucleus on the periphery. Signet ring cell adenocarcinoma associated with E-cadherin mutation. Easy one, do not go wrong in such questions. Which other tumor of the body is also associated with E-cadherin? Which other tumor of the body? Guys, nobody studies this organ as good as well as us. Very right, lobular carcinoma. Breast is not a tumor, breast is an organ. Lobular carcinoma, breast. That was for 4448. Lobular carcinoma, breast. Though you were right about breast. Next, diagnosis. This is question number 10 of your paper. Diagnosis. This is a spotter. The minute you see this, you are able to make out the presence of elongated spindle shaped cells. So it is a mesenchymal tumor, making the diagnosis as GIST. Next, diagnosis. This is a spotter. I want everybody to be right in this. This is question 11 of your slide. Diagnosis. First class. 11. No. Unfortunately, majority answers are wrong. First right answer is 806, which you are the first right answer. Typhoid. Nahi yaar, this is not typhoid. No. What you see here, dekho, there are 2 areas in this. I am getting numerous mixed answers in this. There are 2 areas. One is this one and the other is this circle. Which is the problematic area? Obviously the circle. This, you have a large black arrow on the circle, in the sense that in the paper of course you will not have the arrow. What you see here is granuloma formation. This is not pseudomembranous, not at all. Pseudomembranous shows you the presence of volcanic eruption, neutrophils which are coming out as a volcanic eruption and coming onto the surface. Amoebiasis shows you amoebiasis, I will be showing you that photograph, entamoeba, which is associated with the flask shaped ulcer. We'll see that. What you see is granuloma formation. This is a granuloma bache, making the diagnosis as TB, making the diagnosis as TB, tuberculosis. Next, suppose TB was not in the options, your second best answer would have been Crohn's disease, because in which IBD granulomas are seen? Crohn's. Next, diagnosis. I have just two options in this. First you tell me the diagnosis and then I'll give you the options. Fatafat bache, everybody. Diagnosis. No. Oh my god, no. Varied answers. Lymphangiectasia. Nahi yaar, gadbad ho gaya. TB, in this you will not think of TB. Finally, 598, you are the first one to be right. You are the first one right, 598. I want more people to tell me. Celiac, no. Celiac shows, unfortunately I do not have the soft copy of celiac here, but celiac is one of the easiest slides. Normally intestine has villi crypts. जो ऊपर जा रहा है that is villi, down is crypt. Celiac is flattening of villi with crypt hyperplasia. This is what celiac disease looks like. Giardia nahi, amoeba, pseudomembranous, 883, I know pseudomembranous is your favorite diagnosis, nahi bache. This was a spotter. What you see here is the presence of the normal squamous epithelium, normal squamous, which is getting converted to endocervical cells, with presence of numerous goblet cells. Intestinal metaplasia. Diagnosis, Barrett's esophagus. Now many students get confused whether this is Barrett's or is this adenocarcinoma, because this gland has come down. Bache, this is Barrett's. Look at the gland, the nuclear polarity is maintained. All the nuclei are present on one side of the cell, versus this one, in which again these are glands. You are able to see gland formation with dirty features, loss of nuclear polarity. Some nuclei are on the top, some are on the bottom. Loss of nuclear polarity with hyperchromasia. Adenocarcinoma. Parent organ, fatafat say everybody, which is parent organ? Answer? I can't hear you. I am still waiting for the right answers. Answer, no. How do you know this is breast? No. Uterus? No. Are you even able to see the parent organ in this? You are not. It can be adenocarcinoma of any site, oral cavity, esophagus, stomach, uterus, cervix, vagina, can be anywhere. Do not overdiagnose adenocarcinoma. Versus this one, which shows you the presence of colon, 686. Nahi bache, it could be any site. You do not have the parent organ. Next, what you see here is a malignancy with prominent nucleoli. That is, it is a malignancy of squamous origin with presence of a keratin pearl. That is squamous cell carcinoma. So we have seen Barrett's, adenocarcinoma and squamous cell carcinoma. Next, diagnosis. Unfortunately, it is already written below that. I should have rubbed it out. What this is showing is cryptosporidia. Cryptosporidiasis, that is question 12. The answer is A. Cryptosporidiasis. This is question number 12 of your paper. These are the small blue spherules which appear on the top, of the brush border. These are the small blue spherules. This is cryptosporidiasis. This is an important prospective question. This as well as the flask shaped ulcer of amoebiasis. The minute you see this, it looks like a flask shaped ulcer, amoebiasis. See, how do I know this is an ulcer area? Because this is the normal epithelium which you are seeing, whereas here the epithelium is denuded. What is an ulcer? Denuded epithelium. Next, diagnosis. This was almost everybody's favorite diagnosis in the previous slides. Answer, diagnosis. What do you see here? Be unbiased. Do I have the printed photograph of this? No, we do not. Diagnosis, be unbiased. Again an important slide. Answer bache. what you see is the RBCs. The red colored cells are the RBCs which the organism is ingesting. That is hemophagocytosis. Hemophagocytosis associated with Entamoeba histolytica. Associated with Entamoeba histolytica, hemophagocytosis. The organism is ingesting the RBCs. Next, mutation associated with this. 1, 2, 3, 4. Let me slightly get on the slide. 1, 2, 3, 4. You have the slide given to you, the mutation seen. Mutation 1, 2, 3, 4. Answer, I have majority right answers. MUTYH. देखो बच्चे, this is not ecadherin, this is not signet ring cell carcinoma. KRAS and WNT belong to the same pathway, so they are out. MUTYH. So this means this is the precursor. Is this adenocarcinoma? No, this is not adeno. This is the precursor lesion of MSI pathway. What is the precursor lesion of MSI pathway? Sessile serrated adenoma. The precursor lesion of the MSI, microsatellite instability pathway, is sessile serrated adenoma. Serration means knife has those serrations. All these are the serrations that you are able to see. Sessile serrated adenoma, SSA. Next, question 14, diagnosis. This is question number 14 in your printed paper. Diagnosis. Miliary TB, not at all. Lobar pneumonia, no. Now I have started getting right answers. I want more people to tell me bronchiectasis. Bache, what you see here is dilatation of bronchi and bronchioles. Bronchiectasis. Differentiate it from the other options, that is centriacinar emphysema. See, appreciate the normal lung. All this where you are able to see the presence of small lesions, or lesion is the wrong word, small spongy feel, that is the normal lung, with presence of the arrow marked emphysematous areas. This is centriacinar emphysema. This is centriacinar emphysema versus where the whole lung is diffusely dilated, that is panacinar emphysema. What is the difference between emphysema and bronchiectasis? Emphysema is dilatation distal to terminal bronchiole, whereas bronchiectasis is dilatation of bronchi and bronchioles. So we have seen emphysema versus bronchiectasis. Next, now I can, before I go to the pneumonias, I can divide pneumonia into two types, typical and atypical. Typical pneumonia is further of two types, lobar pneumonia and bronchopneumonia. You know this. Lobar pneumonia, a part or whole lobe of the lung is involved. A part or whole lobe of the lung is involved. So versus bronchopneumonia, which is patchy involvement. So I can safely say that lobar pneumonia is unilobar in nature versus bronchopneumonia, which is multilobar in nature. I guess all of you are okay with this. So come to this diagnosis, lobar pneumonia. My question to you is, which part is affected, upper or lower, 1 or 2, which is the affected part, 1 or 2, फटाफट से. No, I again have mixed answers. नहीं बच्चे, this is the nice normal lung. I know this, even in live classes I get this answer as wrong. The upper part is the normal lung, whereas the lower is the lobar pneumonia part. This is the affected portion, lobar pneumonia. Versus this slide, in which you are able to see the patchy involvement, versus here where you are able to see patchy inflammation or involvement, which is multilobar in nature, So diagnosis, bronchopneumonia. Next, diagnosis. Answer. Now this, firstly, there is absolutely no problem in identifying it as a lung even in a no history slide. The problematic area are the small white tubercles which you are able to see on the lung. Miliary TB, nahi yaar, 66329, please don't say this as bronchiectasis. These are the normal structures. What you have here is the hilum of the lung. Please do not confuse this with bronchiectasis at all. What the issue in this slide is the presence of these small white tubercles which you are able to see, which is miliary TB, which is miliary TB. Next, diagnosis. No, just the 1 2 3 4 will be sufficient. We have already seen this. No, 217 blunder, 925 no, गड़बड़ हो गया. I don't know why so many of you are telling me. Firstly, there is no SCC, either squamous or small cell. Next point, majority of you, I don't know why are saying the answer to this as carcinoid. नहीं यार. Now finally I have started getting right answers. Majority were wrong. I guess I had 7 right answers. What you see close to 25 were wrong. Now I am getting right answers. Fair enough. What you see is the presence of glandular arrangement of cells with glands having abnormal nuclear features. Diagnosis, adenocarcinoma. Never confuse this with squamous, small cell and carcinoid. I will show it to you. So before we go further, let us see your favorite answer, small cell carcinoma. Microscopically, small cell carcinoma shows us two features. First is nuclear molding. Nuclear molding means the nuclei, they are molded into each other. Nuclear molding, it is a very cellular slide. Still nuclear overlapping is not taking place. The nuclei are molded into each other. Nuclear molding. And the next feature of small cell carcinoma is Azopardi effect. Azopardi effect, this is basophilic staining of vessel wall. That is, the vessel wall, it should be pink in color, but here it is basophilic staining of vessel wall. The vessel wall, it appears blue. Why? Because of entrapment of nuclear material. In the vessel wall. And why is the nuclear material getting entrapped? Because of tumor cell necrosis. So small cell carcinoma lung, two microscopic features, nuclear molding and Azopardi effect. Now have a look at this slide. Be unbiased. This is a very cellular slide. Still nuclear overlapping is not taking place. Look at the cells of your choice. All the nuclei, they are molded into each other. Look at any cluster, bache. Look at absolutely any cluster. All the nuclei are molded into each other. Nuclear molding, small cell carcinoma. Again an important slide. Only 2 slides have actually been repeated twice. One was Barrett's and the second is small cell. Not identifying this is wrong. You have to do this. I know I do not know how to sugarcoat my words. I am a non-diplomatic blunt person. You have to identify this as small cell. Next, diagnosis. What we see here is the presence of a vessel. How do I know it is a vessel? It is a luminal structure with RBCs in the lumen showing blue vessel wall. Azopardi effect. Occurring because of tumor necrosis. How do I know this is tumor necrosis? Because this is the viable tumor. So this is tumor necrosis. Next, I'll be impressed if you tell me this. Question 16. This is question number 16 in your printed paper also. Question 16. No, this is not PSC. No, 217806. This is not primary sclerosing cholangitis. This is not liver. 806 spleen. No. 112 squamous cell carcinoma. Bache, see, when you were thinking of spleen, I still would have been okay with it, but calling this as squamous cell to gadbad hai na. We have seen squamous cell carcinoma, keratin pearl. This is not squamous cell. Is this a granuloma, fibrinoid necrosis? No. See, this is what happens when we see a no history slide. Malignant hypertension? No. Malignant hypertension, onion skinning. What is getting hyperplastic? The muscle layer. Onion skinning, muscle layer around a blood vessel. Is this a blood vessel? Is this the muscle layer? No. So malignant hypertension, foreign body granuloma, no. You can confuse this with a granuloma, but actually this is not a granuloma. Let me tell you, these are polypoid mucus plugs. These are the polypoid mucus plugs, polypoid mucus plugs of loose connective tissue, called as which bodies present in alveoli or lungs, called as which bodies? No, sarcoidosis, no, गड़बड़ हो गया. Now तो I have given you enough hints. बच्चे, AIMS is always the tougher paper. Which bodies? Creola. नहीं यार, ऐसे मत करो. I know many of you will be non-Hindi speaking. Creola bodies are seen in sputum sample. Is this sputum? No. Mason bodies. Polypoid mucus plugs of loose connective tissue. Mason bodies. So now tell me the diagnosis. Mason bodies are seen in, again an important prospective slide. Diagnosis, they are seen in BOOP. I know it's a very sexy name for a liver disease. This is not pap smear, bache, no. Seen in BOOP, that is bronchiolitis obliterans organizing pneumonia. Also called as cryptogenic organizing pneumonia. Mason bodies, an important slide, please mark this well. Next, diagnosis. Now 1, 2, 3, 4, important, agreed. I already have 1, 2 right answers in this. Perfect, agreed. This is electron microscopy. No, now suddenly the first, by chance the first 2 answers were right, next all are going wrong. देखो बच्चे, calretin WT1 cytokeratin 5. These are the 3 markers for mesothelioma. Let me slightly get on the side. These are the 3 markers of mesothelioma. That means even without the image, I know that answer will not be this. Answer is TTF1 plus, it was in bold. Answer is TTF1, thyroid transcription factor 1, which is seen in adenocarcinoma. This diagnosis is mesothelioma because on electron microscopy it shows the presence of long slender microvilli versus adenocarcinoma, which shows short plump microvilli. This is adeno. So this would be TTF1 positive versus mesothelioma, which would be calretin and WT1 and cytokeratin 5 positive. Next, diagnosis. I guess this is question 18 in your slide. Diagnosis, answer. Perfect. Now I have many people saying it as pap smear, but pap smear is not a diagnosis, na? The clinician, while sending the smear, knows that he has sent you a pap smear. 217 nahi bache, vaginalis, that is clue cells. No. I have numerous right answers. Normal basal cells. No. I just had 3 right answers, and again in the beginning the rest of the answers which I am getting are wrong. CIN, coilocytes, nahi bache. Pap smears is an important topic. You have to know that. Unfortunately, I had only 3 right answers. I am still waiting for more. Intermediate cells, coilocytes, CIN, the cervical intraepithelial neoplasia, the nuclear features should be abnormal. These are normal nucleus, normal squamous cells. The right answers were just by 9 to 5 and stuff. Clue cells, no. Trichomoniasis. This is the classical. Let us spend some time on pap smears. I am totally not satisfied with your pap smear thing. This is trichomoniasis. This is the pear-shaped organism, trichomoniasis. Let us spend some time on pap smear. Pap smears, I need not even tell you that the fixative is 95% ethyl alcohol. All of you know that. Let us start with a normal pap smear. Normal pap smear shows me 2 kinds of cells, squamous cells and endocervical cells. Normal pap smear, squamous and endocervical. Squamous cells are of 3 types, that is superficial squamous cells, intermediate squamous cells and parabasal cells. All these are normal. We are doing a normal pap smear. As we go from top to bottom, the nucleocytoplasmic ratio increases. That is, the nucleus becomes more enlarged, cytoplasm reduces, nucleocytoplasmic ratio increases. Next point, microscopically, this is what a squamous cell looks like. It is a large polygonal cell, abundant cytoplasm. Orangophilia. Orangophilia means affinity for orange color. Orangophilia in a squamous cell denotes keratinization. Denotes keratinization. This is a normal squamous cell. On the other hand, endocervical cells, I can look at them by two views. One is the side view, which will show me the presence of cells in clusters in which the nuclei are present on one side of the cell. That is, nuclear polarity is maintained. This appearance is called as the picket fence appearance. This appearance of endocervical cells is called as picket fence appearance. Versus when I look at the same cells from the top, what I will see is cells in clusters with some gap in between and a large central nucleus. This is the honeycomb appearance. So endocervical cells, it shows us two views: side view picket fence, top view honeycomb appearance. All this is a normal pap smear. So let us come to the images. Starting with the first one, this is nice normal squamous cells, large cells, abundant cytoplasm, dense pycnotic nucleus, normal squamous cells. Next, diagnosis. This is the top view. This is the top view of endocervical cells, in which the cells are present in clusters with some space in between, giving it the classical honeycomb appearance. Versus the side view, in which nuclear polarity is maintained, giving it picket fence appearance, giving it the picket fence. Now look at these two cells. These are the squamous cells. All these are the encircled ones are the squamous cells, in which nucleus has slightly enlarged. Nucleus has slightly enlarged, cytoplasm is slightly less. As compared to a superficial squamous cell, in this the nucleus is slightly large, cytoplasm is less. That is, this is an intermediate squamous cell. This is an intermediate squamous cell. Versus this one, I want you guys to tell me the diagnosis bache, and I want almost everybody to tell me. This is a spotter now. Diagnosis, agreed. HPV, no. I had Arvan to write answers. HPV nahi bache, it's not HPV. Diagnosis, I am still waiting for this. Agreed. Trichomoniasis. Dekho, what we have here is clue cell 69. I know clue cell is your favorite diagnosis. Coilocytes 494. No. What you see here is the presence of pear shaped organism, that is trichomoniasis. This is the classical view. This also was trichomoniasis. Every time to वो लेटा हुआ नहीं होगा. This is trichomoniasis. Guys, revise pap smear as well. I am not satisfied with it. Next, diagnosis. फटाफट से pap smear diagnosis. Agreed. Now everybody is okay. Clue cells, bacterial vaginosis. What you see here is squamous cells जिसके पीछे बहुत सारा कचरा पड़ा है. What is all this kachra? These are the cocobacilli. Cocobacilli which are present adhered to the squamous cells, so the normal boundaries are lost. Clue cells seen in bacterial vaginosis. Next, diagnosis. 77889. How to differentiate Warden-Finkelday cells? But a Warden-Finkelday cell is the giant cell seen in measles. It will be a histopath slide. This is a pap smear, firstly. Secondly, Warden-Finkelday cell will have 25 to 50 nuclei. This has single nucleus. Why are you even thinking of a Warden-Finkelday giant cell while seeing a pap smear? No, gadbad ho gaya. No. Next, diagnosis. We have done this. Clue cells. Diagnosis. No. Candida 8973. Gadbad ho gaya bache. Blunder. No. 8806. No. Coilocytes. No. HPV. No. Candida, no. Actinomycetes, no. No. 217 tadpole cell. I am okay with the fact that you identified this as the tadpole cell, but clinician has nothing to do with tadpoling. You have to sign out the diagnosis to the clinician, no? Diagnosis. The minute you see this slide, you are able to make out that all these were the squamous cells which became abnormal in shape. E. coli, nahi bache, this is a pap smear, no. Which became, the minute you see this, the morphology of the cells is not good. It's a very bad looking slide. So there is marked nuclear polymorphism. Some nuclei are very small, some are very large, some are very large. With hyperchromasia, it is a large black nucleus, irregular nuclear borders, high NC ratio, or with presence of abnormal shape of cells, as she told us, as the spindle cells or tadpole like cells. All these are the features of malignancy. Diagnosis: squamous cell carcinoma. How do I know it is squamous? Because the cells look squamous in origin, firstly, and secondly, keratinization or angiophilia denotes keratinization. So this is a keratinizing squamous cell carcinoma. Next, I'll come back to this. 388 you are telling me it has cervical cancer. How do you know this is cervix? Do not overdiagnose. This can be squamous cell carcinoma of anywhere. Pap smear, Pap-Nicolau smear, if nothing is mentioned, we by default take it as the cervical pap smear, but Pap-Nicolau is just a stain. It can be of the liver, stomach, the pap stain. It can be of the lymph node. So maybe this is squamous cell carcinoma which has metastasized to the lymph node. We do not know whether it is cervix or not. Next, diagnosis. The minute I see this, we know that it was the honeycomb appearance which has spread apart, with presence of prominent nucleoli. You are able to see a large black nucleolus in every nucleus. This prominent nucleoli is called as macronucleoli. Macronucleoli seen in adenocarcinoma. Macronucleoli seen in adenocarcinoma. Next, this is a good one, and unfortunately I did not keep all the pap smear slides with me. Diagnosis. This is question 19 in your printed one. Agreed. Now majority are right. Actinomycetes, but I do not have the soft copy of candidiasis with me here. I cannot show you that, but in candidiasis you should be able to see the presence of fungi. This is a cotton ball like structure. Actinomycetes. The closest actinomycosis. The closest differential diagnosis of this can be a clue cell. Clue cell is cocobacilli adhered to squamous cells. This you can confuse it with cocobacilli, but it is not adhered to the squamous cells. Hence, this is actinomycosis. Next, before I go further, I want a very truthful opinion from majority of you. First, tell me. I know you are seeing numerous slides. Have you ever seen these slides, or you have been exposed to such microscopies before, or is this the first time? Firstly, and are you comfortable with this speed? I do not want to go too fast. Just yes, no, first time. 569. Okay. Bache, I know this. I am getting first time. Majority of you are saying first time, not this much exposure. Okay, few are seen before, comfortable, never exposed. Okay. So kidney pics first time, pap slides first time. Okay. Not able to take pics. 20330, most are new, but you do not even worry about taking the pics. I am saying this very frankly. Right now I am just showing you 100 to 150 slides. This is just a 2.5 hour session. In the end of the class, I will tell you my app, I will tell you the book. In the pathology app, it's just a 15-hour session, 2 days test and discussion module, 15 hours, and majority of the questions, it's exclusively for the AIIMS mock. The price of which for all of you will be ₹1000 only, those who are attending this class. You can buy it online, and majority of the AIIMS questions are prospectively going to come from that. I launched my one day app on 20th December. I guess majority of you would, many of you would be knowing it. It was a 9-hour one day class. There were on January NEET exam there were 28 questions, 22 of which came from those 9 hours of class. For AIMS, I have launched the AIMS module, 15 hours pathology, general, hemat, systemic, everything is being covered. You do that, not to worry. Let us start with this. Everything looks new. 8 to 1, I know, okay, do not worry, take the app, it will go much slower. Right now this is just to give a spectrum that all this is asked. Acha, tell me, not able to recognize the organ, I'll go slightly slower. If you are not able to recognize, I'll go slower. Acha, tell me this, before I go further, should we take a small 2-minute break at this point? Not a longer one, just a 2-minute break before I start with our next organ, that is breast. You are comfortable with it? ठीक है. Majority are saying yes to the break. Not a long one, it's just a 1-2 minute break. Have a glass of water, take in your breath, and then we start with our next organ, that is breast. I guess till now we have covered kidney, liver, pap smears. We have covered 3 major organs. Then we'll go to breast. Have a 1-minute break, it's okay, take your breath. 4541, 10-minute break. That's very sweet बच्चे, but I cannot give a 10-minute break. नहीं यार, I cannot. 880, how to identify the organ? Normal histocells. I'll tell you the organ. Now the issue in a 2.5 hour class, it's the vibe session, is that I cannot go into too much details of it because I have to cover all the 14 topics. There are systemic around 10 chapters, to onco and non-onco hemat plus platelets and stuff. I have to cover those in 2.5 hours. I'm showing you more. I'll try to go slower. I guess we can start. Everybody has taken a deep breath. We can start. Okay. So this starts us with our next slide, that is diagnosis. Now the minute you see this slide, the minute you see this, what you are able to make out, organ. I want you only to tell me organ. This is an important organ, I mean no double meanings. This is as such an important topic because no question has come from this topic till now. And as a pathologist, I see numerous specimens. So it is again an important prospective topic. I'll go slow in this, an important prospective topic. 732 fibroadenoma nahi bache. 248, you are the only one right till now. Breast. This is a nice normal breast. What you see here is the presence of breast lobule. With numerous acini. This is one breast lobule, this is the next one, third one, and so on, with presence of intralobular stroma and interlobular stroma. Some stroma is present inside the breast lobule, intralobular, and between the breast lobules, interlobular and interlobular stroma. The white areas are the fat spaces. So this is a nice normal breast. Young female, pregnancy या old female? फटाफट everybody, young, pregnant या old? The first slide. Answer. I guess you have not been exposed to breast microscopies again. Let us have a good look at this. Here the fatty tissue, old nahi bache, nahi, majority wrong, old no. What you see here, the fatty tissue is less. Majority is the young fibrous stroma. This is a nice firm breast, young female. Now this is low power view, 10x. Throughout breast we will see 10x. The second image is the same low power view in which the breast lobule is massively enlarged. What was just this much in the first slide has massively enlarged with presence of numerous acini. All these are the acini. So this is pregnant female. The second slide is pregnant female versus the third one. So this was a pregnant female versus the third one, which is an old female. How do you know this is breast? Third image. How do you know that this is breast? Answer: by the presence of fat. Nahi. Spoken like a true guy. Wherever fat is present, it's not breast, bache. You identify breast by the presence of small atrophic breast lobule. This is the atrophic breast lobule, making this as breast, with abundant fatty tissue, making this as older female. Making this as older female. So this is a nice normal breast, young, pregnancy, and older female, Next point. So let us now start with question 20. Question number 20, diagnosis. What you see here, no, it's not a papilloma. D, comedo, no, gadbad ho raha hai. Nahi bacha, I do not have even a single right answer till now. No. 30090, okay, now I have two right answers. 5925, majority are wrong. Comedo, no. Cribriform, no. Let me speak. Majority of you are wrong in this. What you see here is the presence of a breast duct. This is an enlarged breast duct with presence of numerous cells in the lumen. Is the empty space elongated or is it slit? Is it elongated slit like or is it round? Elongated slit like. Diagnosis: epithelial hyperplasia. What you see here is the presence of an enlarged duct. Guys, Okay. So this gets us back to this slide. What we see here is the presence of an enlarged duct with multiple cell layers, with presence of multiple cell layers with elongated slit-like spaces. All these are the elongated slit-like spaces. elongated slit-like spaces. So diagnosis, epithelial hyperplasia. Next, coming to this one, question 22. The question was relative risk in this. Answer, firstly, have a look at the diagnosis. This shows the presence of an enlarged duct with numerous papillae. All these are the papillae in which you are able to see something pink inside it. So diagnosis, intraductal papilloma. Diagnosis, intraductal papilloma. What you see here are the enlarged papillae with a central fibrovascular core. Papillary structures with central fibrovascular core. The pink areas are the fibrovascular core. It looks like a papillary structure, intraductal papilloma. Question was relative risk in this. The relative risk in this is the second category of epithelial breast lesions, that is proliferative breast disease without atypia. I can divide the epithelial breast lesions into 5 categories. Epithelial breast lesions can be divided into fibrocystic disease. They can be divided into fibrocystic or the non-proliferative breast disease. Next, proliferative breast disease without atypia. Next, proliferative breast disease with atypia. Next, carcinoma in situ and carcinomas. These are the epithelial breast lesions. Now coming to the relative risk in each category. Category 1, relative risk 1. Category 1, it does not increase the risk of breast cancer, so relative risk 1. Category 2, relative risk 1.5 to 2. Category 3, 4 to 5. Category 4, 8 to 10. Category 4, 8 to 10. Category 5, cancer has already developed, so there is no concept of a relative risk. Hence, the diagnosis in the previous slide was intraductal papilloma, which is a category 2 lesion, that is, it is a proliferative breast disease without atypia. So relative risk 1.5 to 2. Next, diagnosis. Now in this case, the parent organ is not there. You do not know that this is breast. I am telling you that this is a breast slide, which is showing you the presence of enlarged ducts, having multiple cell layers with hemorrhage and calcifications. Diagnosis, comedocarcinoma. Enlarged duct, multiple cell layers, hemorrhage and calcifications, comedo. Next, so I can divide ductal carcinoma in situ into 2 types, that is comedocarcinoma and non-comedocarcinoma. Non-comedocarcinoma is of 5 types, but the 2 main ones are micropapillary DCIS. And the cribriform type. This is ductal carcinoma in situ. We have already seen that comedocarcinoma looks like this. Now coming to the next set, what you see here is again the presence of an enlarged duct with round spaces. Remember, epithelial hyperplasia had elongated slit-like spaces. These are the round spaces. Diagnosis, cribriform type. Of DCIS. Cribriform ductal carcinoma in situ, giving it the classical which appearance? Cookie cutter appearance. This is cribriform DCIS. Next, coming to the other side, what you see here is the presence of an enlarged duct, with numerous papillae. All these are the papillary structures, but they lack the central fibrovascular core. See, in intraductal papilloma, the central pink area was present, a fibrovascular core was present, which is not present here. So diagnosis, this is the micropapillary DCIS. So this is how we differentiate the intraductal papilloma from micropapillary DCIS. Next, diagnosis. What we see is, it is given to you that it is the ER-PR HER2/neu slide. In this you are again not able to make out breast, but the minute estrogen receptor, progesterone and HER2/neu receptor is given, so what is it? Nahi bache, you cannot just comment on this. You have to see that the left hand side is ER-PR HER2/neu negative versus the right side in which the brown stain is coming as positive. The minute you have the presence of a brown color, it means it is positive. So this is ER positive, PR and HER2/neu positive. I need not tell you, estrogen and progesterone receptor are the nuclear stains. These are the nuclear stains versus Herceptin receptor versus HER2/neu, which is a membranous stain. So this gets us to question number 21. Question 21. True in triple negative breast cancer. The left side image was given, all were negative. True in triple negative is, it is associated with a bad prognosis, not good. Microscopically has medullary morphology. This is a true fact. Precursor lesion is flat epithelial atypia. No, all this is false. The precursor lesion in triple negative is unknown. Flat epithelial atypia is the earliest recognizable precursor. Flat epithelial atypia. This is the earliest recognizable precursor. It is the earliest recognizable precursor of ER positive HER2/neu negative breast cancer. Flat epithelial atypia, this is the earliest recognizable precursor of estrogen receptor positive, ER positive HER2/neu negative breast cancer. Next, question 23. Diagnosis. This again is a spotter. The parent tissue is not there. If you have to make if I am telling you this is from the breast, what you see here is the presence of cells which are present in a single column fashion or a single line fashion, called as the Indian file pattern. Lobular carcinoma breast. Next, but the parent tissue was not there in this slide. Next, again an important slide, diagnosis. This is what we had started with as the first one, diagnosis. The minute you see this, you are able to make out the lobular architecture. All these are the lobules, very right, fibroadenoma. What we see here is proliferation of intralobular stroma. The stroma is proliferating, as a result of which the acini are compressed. Remember the normal slide, they were acini with less stroma. Here it is intralobular proliferation of the stroma. Diagnosis, fibroadenoma. This is a no history slide, fibroadenoma. Next, diagnosis. This is question number 24, diagnosis. What you see in this, the first is the gross image, which is showing you a yellow white solid component with numerous cystic areas. This is a yellow white solid tumor with numerous cystic areas. Not concerned. What I am very much concerned with is the microscopy. Microscopically, it is showing me a tumor in which it is a globuloid structure with presence of eosinophilic areas in between. This looks like a telephone. Receiver उठाया and center से dial कर लिया. Call Exner bodies. seen in call-Exner bodies, seen in granulosa cell tumor. Call-Exner bodies seen in granulosa cell tumor. Next point, in the ovaries we talk of two main bodies, call-Exner bodies, granulosa cell tumor. We have already seen in that you see the presence of eosinophilic areas with tumor cells which are present around it, call-Exner body, and the second is the presence of Schiller-Duval bodies. Second is the presence of Schiller-Duval bodies, which are seen in, this is what a Schiller-Duval body looks like. You have the presence of a papillary structure around the central blood vessel. Matlab, have a look at all these. This is the blood vessel. This is the blood vessel. How do I know this? This is the blood vessel. It has RBCs in the lumen with a papillary structure around it. Exactly, seen in yolk sac tumor. Identifying a Schiller-Duval body is tougher. Identifying a call-Exner body is easier. So if it is not call-Exner, simply close your eyes and mark it as Schiller-Duval bodies, yolk sac tumor. Next, question 25, testicular tumor diagnosis. What you see in this is the presence of sheets of tumor cells. The tumor cells are present in sheets in which the parent organ is not there. The examiner is telling you that this is from the testis. Small nuclei, clear cytoplasm around it. Seminoma. Exactly. Majority of you were right in this. Seminoma. You have sheets of tumor cells, clear cytoplasm, small nuclei. Next, diagnosis. Now this again is a spotter. Firstly, identify the parent organ, thyroid. How do I know this is thyroid? Because it is showing me the presence of thyroid follicles with colloid inside it. Now what is the problem in this? Thyroid microscopies, I guess you would have been exposed to it previously also. What you see is scalloping of colloid. Right next to the thyroid follicular cells, colloid is being taken up by thyroid follicles, making this as, which is not papillary thyroid carcinoma at all, making this as Graves' disease. Scalloping of colloid. Graves' disease is thyrotoxicosis. It is hyperthyroidism, thyrotoxicosis. Colloid is taken up by the thyroid follicular cells and converted to T3 and T4. Graves' disease. Next, diagnosis. Again, first identify the parent organ. What you see here is the presence of thyroid. This is thyroid. On the right hand side, we see the presence of dense lymphocytic infiltrate with well defined lighter areas, that is the germinal centers. Diagnosis, Hashimoto's thyroiditis. This question came in the paper. One of the options was Hashimoto's. Many students got confused between medullary carcinoma, thyroid and Hashimoto's. Have a good look. What happens is, when you are seeing the slides chapter wise, that is what we are doing, it is slightly easier, but when it comes in the paper with a tougher slide, we tend to get confused with it. I am showing you the whole spectrum. So this is Hashimoto's. Next, now this is one of your favorite diagnoses. Firstly, parent organ, thyroid. How do I know this is thyroid? Because it shows the presence of thyroid follicle with colloid inside it. Thyroid showing the classical orphan annii nucleus. All these are the large nuclei. Orphan annii nucleus. It is a large nucleus with prominent nucleolus. Which is the diagnostic hallmark of PTC, papillary thyroid carcinoma. You know it is thyroid because of the presence of thyroid follicles with orphan annii nucleus, PTC. Next, diagnosis. Identifying the parent organ is easy. Thyroid. See the presence of thyroid follicles with colloid inside it. What you have here, no, it's not medullary at all. What you see here is the presence of varying sizes of thyroid follicles. Some are very large, some are intermediate sized. but there is a predominance of microfollicles. Are you able to make out these small follicles with colloid inside it? This is predominance of microfollicles. Predominance of microfollicles, that is follicular neoplasm. Predominance of microfollicles, follicular neoplasm. I do not know whether this is follicular adenoma or carcinoma. For that I need capsular invasion or metastasis. Next, diagnosis. Now in this, the parent organ is again not there. I am telling you that this is from thyroid. What you see here, all these blue cells are the tumor cells. All these blue ones are the tumor cells with presence of extracellular pink material, that is amyloid. Which thyroid cancer is associated with amyloid? Medullary carcinoma thyroid. Medullary carcinoma thyroid. You see the presence of sheets of tumor cells with sheets of tumor cells, which is not anaplastic, medullary. The tumor cells have a similar size. Anaplastic carcinoma, some nuclei will be very small, some will be very large. There will be marked nuclear polymorphism in anaplastic. This is sheets of tumor cells with extracellular amyloid. Differentiate amyloid from colloid. Colloid is much finer versus amyloid, which is coarser in texture. Next, this is a good one. Question 27, diagnosis. I'll be glad if you're able to tell me this. Diagnosis. Question 27. Parent organ, thyroid. How do we know this is thyroid? Because of the presence of thyroid follicle. Semoma body totem, no, garbad ho gaya. What you see here is thyroid follicle with colloid inside it. No, I'm still waiting for the right answer in this. See, what happens in the paper is you will be directly given this slide. I showed you the easier ones also, but you can be directly given the tougher slide also. Diagnosis, anaplastic, no. Is this a malignancy? Are the nuclear features abnormal? No. Let us rule it out. Is it Graves? No. Hashimoto's? No. Follicular neoplasm? No. What is the problem in this? Problem is you are able to see the presence of a giant cell with multiple nuclei. Giant cell. Identify the giant cells. I am not asking you to identify the ill-defined granuloma. This is the granuloma. Even if you are not able to identify it, you can see the giant cell. That is decurvens or granulomatous thyroiditis. Decurvens or granulomatous or the granulomatous thyroiditis. This again is an important prospective slide. Thyroid. Next. Question number 28, diagnosis. Question 28, diagnosis. What we see here is the presence of spironolactone bodies. All these are the spironolactone bodies. They are the spironolactone bodies. What are spironolactone bodies? These are eosinophilic laminated cytoplasmic inclusions. These are eosinophilic laminated cytoplasmic inclusions. Eosinophilic laminated cytoplasmic inclusions. This is exactly what a classical spironolactone body looks like. Associated with primary hyperaldosteronism. Associated with primary hyperaldosteronism, that is Conn's syndrome. Primary hyperaldosteronism, that is Conn's syndrome. They are found after therapy of spironolactone bodies. We have already seen thyroid. We will be seeing three features. We will be seeing three features in endocrine: thyroid, primary hyperaldosteronism, that is Conn's syndrome, and the last is the Zell-Bellin pattern. Question 29, the Zell-Bellin pattern, which is associated with pheochromocytoma. Zell-Bellin pattern associated with pheochromocytoma. What you see in this is the presence of clusters of polygonal cells surrounded by sustenicular cells. See, these are all the clusters which are being formed, a nest like pattern. I'm not even concerned which cell is this. This is the classical cell Bellin pattern, pheochromocytoma. Pheochromocytoma. Next, I need not even tell you that synaptophysin and chromogranin are the chief cell markers. Next, question number 30. Which collagen is seen in this? Question 30. Which collagen is seen in this? From the Delhi students, I am getting a request ki, sir, we have seen these slides, you can go slightly faster. Fair enough. This is as such a repeat slide. What you see here, firstly, which stain is this? Mason's trichrome. MT. The stain is Mason's trichrome, in which the muscle collagen is blue, muscle is red. What are these dark red cells? These are the RBCs which are present in the blood vessel. That is, new vessel formation or angiogenesis is taking place. So diagnosis, granulation tissue. This is granulation tissue. So all the examiner was asking you was, which is the most common collagen present in granulation tissue? And the answer is type 3 collagen. Type 3 collagen. When granulation tissue progresses to scarring, type 3 is replaced by type 1 collagen. Next, question 31. Question 31. From the options itself, you can make out that this is a slide from the heart, which is showing you the presence of a heart valve. Which is showing you the presence of a heart valve. On this side is the heart valve with an overlying endothelium. The very thin layer is that of the endothelium with a large thrombus. With the presence of a large thrombus. Thrombus is aggregate of RBCs with platelets, large thrombus on the heart valve. There is no inflammation. There is no inflammation at junction of heart valve with the thrombus. No inflammation at junction of heart valve with the thrombus. So diagnosis, NBTE, non-bacterial thrombotic endocarditis, which is, this is not infective endocarditis. In infective endocarditis, there should be inflammation at the junction. Infective is because of an infection, it would be associated with inflammation. Here there is no inflammation. Next, question 32, diagnosis. An easier one, diagnosis. Answer. What you see here is the presence of a blood vessel. This is a blood vessel. Which is the problematic area? Necrosis, hypertension, no. Garbad ho raha hai. Agreed. Finally 514, you're the first one, right? Now I've started getting right answers. What you see here is the presence of calcification in tunica media of the vessel wall. You're able to see calcification in the muscle layer of the vessel. How do I know this is a vessel? This is the lumen with presence of RBCs in the lumen. Calcification in the muscle layer. That is Monkeberg's medial sclerosis. That is Monkeberg's medial sclerosis. Next, which type of calcification is this? Is it dystrophic calcification or is it metastatic? This is dystrophic calcification, Monkeberg medial sclerosis. Next, diagnosis. Answer. Now, what you again see, this is one of the easiest slides, vessel with lumen. Lumen is narrowed. Most common cause of narrowing of lumen, atherosclerosis. Atherosclerosis of the vessel, it shows us, atherosclerotic plaque shows us 3 areas. This is the fibrous cap, the shoulder area and necrotic core. So diagnosis, atherosclerosis. This was an easy slide. Next, this is the gross image. Diagnosis. The image itself shows you the presence of large friable vegetations. देख के ही नजर आ रहा है कि बड़ी हैं, large friable मतलब they can break off and go to distant sites. Large friable vegetations, infective endocarditis. Which is, this is not a Libman sac. Libman sac endocarditis shows the presence of vegetations on both sides of the heart wall, more common on the undersurface. This is infective endocarditis. Done. This finishes your systemic pathology portion, which was the heavier and the much tougher one. This gets us to the other side, that is hematology. Now before I go further, how to target the aims? See, I'll tell you this. I am MBBS MAMC, MD Path UCMS, resident hemato-oncology, AIMS Delhi. I have cleared all my 3 papers in the first attempt from general category, not on the basis of hard work. See, all of us work hard, we are medicos. Hard work takes you to a level. What gets you selected is the attitude and approach to the question. So firstly, most important thing is make a schedule. Make a schedule. You have approximately 50 days left for the paper. Target the paper well. Do not be distracted by anything. Target the paper well. Do not be underconfident. Do not be overconfident. We can divide the subjects into major, minor and the ultra short subjects. There are 9 major subjects. Give 4 days to each major subject, 2 days to the minor subjects, and ultra short, that is your radio, derma, anesthesia, psychiatry and ortho. These are your 5 ultra short subjects. Give it a total of 5 days. You can divide it according to which one you are better at, which one you are not. Follow this 4-day, 2-day, 1-day schedule. Do the previous 4-year papers minimum in the remaining 4 days. Go and give the paper. You will go through it and have faith. With respect to pathology, for the images that we have seen and stuff, it's my very sincere advice, go for the 2-day test and discussion module, which is for 15 hours, which will take care of your pathology. Next, so this gets us to our next question, 33. Now starting with hematology, this is peripheral smear. How do I know that? Because RBCs are well spread apart, showing the presence of all these are the neutrophils. Which is this cell? Eosinophil. Please don't call this one as basophil. I agree that the diagnosis is CML, high TLC with eosinophil. These spot the basophils in the slide. These are the basophils. Large blue granules, basophils. In a case of CML, you can be asked individual cells with an arrow. Just calling this as CML is not sufficient. You have to identify the cells with immature myeloid precursors. High TLC, shift to the left with basophilia. Diagnosis CML. Next, diagnosis. Again, peripheral smear showing the presence of large cells, 2.5 to 3 times the size of an RBC, moderate amount of cytoplasm with cytoplasmic granules. Nahi bache, this is not ALL. What you see, cytoplasm is moderate in amount. Moderate amount of cytoplasm, CLL nahi, gadbad ho raha hai. Moderate amount of cytoplasm with cytoplasmic granules. Diagnosis AML. I had varied answers, multiple myeloma, APML, CLL. Dekho, let us start with CLL. Chronic lymphocytic leukemia, CLL, it shows mature appearing lymphoid cells. So the size of the lymphoid cell will be similar to the size of an RBC. Here they are much larger than an RBC. So they are the myeloblasts. They are blasts. How do I know myeloblast? Because of cytoplasmic granules. Differentiate this AML from this case. What we see here is again the presence of large cells, 2.5 to 3 times the size of an RBC, scant cytoplasm, no granules. ALL, acute lymphoblastic leukemia. Next, diagnosis. See, what we see here is large cells, 2.5 to 3 times the size of an RBC, again showing the presence of OR rods. Is it a single OR rod or are there multiple OR rods? They are multiple OR rods in a single cell. Diagnosis M3. Please do not call this as M3, M4, but M3. Diagnosis M3. And such cells are called as faggot cells. Which is the most common translocation in M3? Most common translocation in M3? Translocation 15-17. So when the question will come on this, they will not just ask you the diagnosis M3, fair enough. Translocation seen in this is translocation 1517, fusion transcript PML RARA. Fusion transcript PML RARA. This is M3. Next, diagnosis. Question 34 of your slide, diagnosis. What we see here is the presence of pseudo Gaucher cells. But please do not call this as CLL. No. I had the first 6 answers as CLL. Nahi bache. CLL shows you mature appearing lymphocytes. The abnormal cell is this one. This is of course much larger than a RBC. CLL, this is not a smudge cell, this is not a case of CLL. This is pseudo Gaucher cells. Again, an important prospective question has not been asked till now. This is a pseudo Gaucher cell or C. blue histiocytes. Pseudo Gaucher cell or C. blue histocytes. C. blue histocytes. How do I know this is a pseudo Gaucher cell? Because it is a macrophage. It is a very large cell with wrinkled blue-green cytoplasm. That is a C. blue histocyte or the pseudo Gaucher cell seen in CML. Next, diagnosis 1, 2, 3, 4. I want majority of you to tell me in this. This is a spotter now. I guess we have already discussed this. You are given the slide, question 35, diagnosis 1, 2, 3, 4. I just have one right answer till now, 8, 7, 8. But you are right. Dekho, you have the presence of cells. You have cells in which something blue is present in the cytoplasm. It means, of course, this is not the normal HE stain. This is a special stain in which something is getting stained blue. What gets stained blue? Prussian blue stain, iron. Diagnosis, MDS, RARS. Myelodysplastic syndrome, it shows the presence of dysplasia, refractory anemia with ring sideroblasts. Ring sideroblasts shows the presence of iron in the cytoplasm. So diagnosis, RARS. How many of the erythroid series cells should be ring sideroblasts? More than 15%. More than 15% cells of erythroid series should be ring sideroblasts to make the diagnosis as RARS. Next, question 36, diagnosis. Again a no history slide. You have the presence of peripheral smear. These are the two abnormal cells which look like neutrophils. But the problem is that they are hypolobated. It just has 2 lobules. So hyposegmented neutrophils, and even the cytoplasm is hypogranular. I am not able to see granularity of the cytoplasm. So this is which anomaly of MDS? See, any abnormal cell is myelodysplastic syndrome. This is the pseudo-Pelger-Hue abnormality. Pseudo-Pelger-Hue anomaly seen in neutrophils. Pseudo-Pelger-Hue anomaly seen in neutrophils. What we see here is hyposegmented neutrophil with hypogranular cytoplasm. Next, diagnosis. Answer. Which cell is this? This is a very large cell with 3 nuclei. So this is a megakaryocyte, and very right. Nahi bache, this is not a mott cell. Please do not confuse this with the plasma cell. Platelet, nahi, megakaryocyte. By platelet, I hope you meant the precursor, that is megakaryocyte, showing you the classical pawn ball megakaryocyte. This is what a pawn ball looks like, showing you the classical pawn ball megakaryocyte. Pawn ball megakaryocyte in the West, if somebody was short of money, they used to go to the pawn shop, that is, you keep over this stuff and give us money. They used to have this symbol on their shop. spawn ball megakaryocyte. This is hypolobated in nature. It has less number of lobules, less nuclear segments. Hypolobated megakaryocyte seen in MDS. Next, a good question. Question number 38. Question 38. Diagnosis. No, I know CLL is your favorite diagnosis. नहीं बचे 217 नहीं. देखो, I am again saying this. CLL should have the presence of cells similar in size to an RBC. These are the RBCs. These are the abnormal cells. They are much larger. They are much larger than an RBC. So it is not CLL. Firstly, do not confuse every cell with a smudge cell. Next, what you have here also is the presence of an OR rod. You have this cell with OR rod. So it is a blast. It is a myeloblast with monocytic differentiation. This is what a monoblast looks like. Diagnosis AML M4. Diagnosis AML M4. This is what monoblast. The cytoplasm is slightly more with few cells showing vacuolations. This is AML M4. Have a good look at this. Next, diagnosis. This is a spotter. Question 39. This is even printed in your paper. This is a spotter, bache. This is a spotter. Diagnosis, starry sky appearance. Stars are the macrophages in a sky of Burkitt cells. Burkitt's lymphoma. Burkitt's lymphoma. Starry sky appearance. This starry sky appearance in Burkitt's is seen in which technique? Peripheral smear, bone marrow aspirate, bone marrow biopsy. Answer? Peripheral smear, no. Nahi bache, I've landed you in that trap. Lymph node biopsy. Burkitt's lymphoma. Stars are the macrophages. Starry sky, that is Burkitt's. In kidney, we saw starry sky appearance with PSGN. That was immunofluorescence. This is lymph node biopsy. Next, diagnosis. Diagnosis. So when you get this slide, you can simply be asked which cell neoplasm is this? A B cell or a T cell neoplasm? These are the Sézary cells. What you have here is the presence of Sézary cells with cerebriform nuclei. They look brain-like. Sézary cells, cerebriform nuclei, which is a T cell neoplasm. Which is a T cell neoplasm. Sézary cells. Next, an important slide which even came in this paper. Diagnosis. Diagnosis. In the exam, majority of the students confuse this with plasma cells. Nahi bache. What you have here, I have even marked it with an arrow. No, this is not a hairy cell. No, Langerhans cell histiocytosis. This is a slide of Langerhans cell histiocytosis. Question 41. Langerhans cell histiocytosis. What you see here is cells with oval nuclei. Oval nuclei with longitudinal grooves. Oval nuclei, you are able to appreciate the grooving very well. All these are the oval nuclei with longitudinal grooves. With longitudinal grooves, giving it the classical coffee bean appearance. Giving it the classical coffee bean appearance. Langerhans cell histiocytosis. So the question can very well be, what is the marker seen in Langerhans cell histiocytosis? Answer, they are CD1A, S100 and CD207 positive. Markers in Langerhans cell histiocytosis, they are 1A, S100 and 207. On electron microscopy, it is associated with Burbach granules, giving it the classical tennis racket like appearance. Giving it the classical tennis racket appearance. Next, diagnosis. I am telling you that this is bone marrow biopsy. Diagnosis. We have already seen these cells. Large cells, abundant cytoplasm, eccentric nucleus. Plasma cells seen in multiple myeloma. So bone marrow biopsy, plasma cells, multiple myeloma. Liver plasma cells, autoimmune hepatitis. Next, question 42. Next, question 42. Diagnosis. This is a spotter. This is a spotter. You have peripheral smear showing the presence of cells with hairy cytoplasmic projections. Hairy cell leukemia. Hairy cell leukemia. Now, I am not showing you this slide for the peripheral smear. Look at the bone marrow biopsy. Look at the bone marrow biopsy. The bone marrow biopsy of hairy cell leukemia has the classical fried egg appearance. It has the classical fried egg appearance. It looks like eggs have been fried. Fried egg appearance, hairy cell leukemia. Next, which technique is this and the diagnosis? This is FISH. We have discussed this numerous times. Fluorescent in situ hybridization. This is FISH, in which translocation is positive. How do I know that translocation is positive? Normally, just by seeing this, FISH is the investigation of choice for detecting any fusion transcript. Suppose I have to detect BCR-ABL. Just by seeing this, I do not know this is for BCR-ABL. Say I will give red color to ABL, green to BCR. I can give it any color. Red and green are the most common ones. So I should be able to see 2 red, 2 green. I should be able to see 2 red, 2 green. That is normal. Here a translocation has occurred. So we see the presence of a third color. That is a yellow color. So translocation is positive. FISH. Next, diagnosis. Diagnosis. Answer. 3 stains, MGG, SBB and PASS. Diagnosis. Agreed. I have the first right answer, 878. You are very right, bache. MGG, majority of you would not be knowing the full form. Me Grunwald Jimsa. Does not matter. Whatever the full form is, does not matter. This is peripheral smear showing you the presence of large cells. They are much larger as compared to an RBC. So these are blasts, which are Sudan black B positive. Nothing can be more black than this. Sudan black B positive. PASS negative. You very well know myeloperoxidase and Sudan black B are stains for myeloblasts. So diagnosis AML. Diagnosis acute myeloid leukemia, AML. Next diagnosis. This is an interesting slide. I want more people to tell me. Diagnosis. Should I repeat this one? Everybody is okay with this? Just yes no answer. I guess this was an important slide. This was AML, Sudan black B positive AML. Next, diagnosis. Question 45, diagnosis. This is an important slide, bache. Spherocytes, no. Spherocytes, they should lack the central pallor. Here, all the RBCs have the central 1/3 pallor. So, spherocytes is out. Next, Burr cells. नहीं बचे, Burr cells should show the presence of spicules in RBCs. There are no spicules. G6PD rouleau formation. G6PD is bite cell. You should be able to see a bite cell. There is no bite cell, no rouleau, nothing. Howell Jolly anemia नहीं बचे. This is a nice normal peripheral smear. Before we go on to the abnormalities, this is what a normal RBC looks like. This is a lymphocyte. All the small ones are platelets. This is normal. There is no rouleau. Such overlapping of 2 cells is allowed. It's not rouleau. Next, this was a normal sized smear. Compare it with this. Here the RBCs are much larger than normal and they are oval in shape. Macroovelocytes. Macroovelocytes, which is the characteristic RBC morphology of megaloblastic anemia. Next point. This cell can be asked with an arrow. This is a megaloblast. This is a nucleated RBC. This is a nucleated RBC showing nucleocytoplasmic asynchrony. This is a nucleated RBC showing nucleocytoplasmic asynchrony. That is, the nucleus is larger but the cytoplasm has matured. Nucleus and cytoplasm is not in synchrony with each other. 541 previous one, but there is nothing to discuss in this. This is a nice normal peripheral smear. This is the normal size of an RBC. It is not showing any RBC abnormality versus this one, which shows us two features: macroovalocytes and nucleocytoplasmic asynchrony, which is the characteristic feature of a megaloblast. Next, this is a good slide. Diagnosis. Question 47 in your paper. Diagnosis. Answer. Diagnosis. Agreed. Now I had 3 right answers. Firo to bache, iron deficiency anemia is out. See, what you see in this is microcytic hypochromic RBCs. All these are very small microcytic hypochromic RBCs with presence of numerous target cells. And what are all these cells? These are the nucleated RBCs. See, around each nucleus you are able to see a cytoplasm. Nucleated RBCs. Increased number of nucleated RBCs should tell us that the reticulocyte count is high. That is why immature RBCs are coming in peripheral smear. High retic count, microcytic hypochromic, target cells. Diagnosis: thalassemia. Minor, major? Major. Thalassemia major. As such a bad picture, severe anisopoikilocytosis, variation in size, shape, everything will never be seen in thalassemia minor. This is a feature of thalassemia major. Next, diagnosis. Question 48. Diagnosis. Answer. No, this is not lung. Now normal lung, nahi, dry tap, गड़बड़ हो रहा है. देखो बच्चे, dry tap is okay, but dry tap is not a diagnosis. Normal bone marrow, no. Smart bird, no. Myelofibrosis, no. I had 6-7 right answers, rest no. Dekho, firstly, when you confused it with lung, you thought these are the normal alveoli. If this is the alveoli, then what about this? No? This is bone. So this is a bone marrow biopsy. Showing the presence of numerous fat spaces. All this is fat with presence of few hematopoietic cells. If I have to give the percentage of hematopoietic cells to this would be less than 5% hematopoietic cells. You know, aplastic anemia shows less than 25% hematopoietic. So diagnosis: aplastic anemia. For calling this as myelofibrosis, you should have seen fibrosis. There is no fibrosis in this. Lung is absolutely out. It is not a lipoma. Lipoma lung, bache, you missed out on the bony tissue. This is bone marrow biopsy. Next, question 49. This is a spotter. 49. Answer. Blood vessel, RBCs in the lumen with presence of fibrin-like degeneration of the vessel wall. Fibrinoid necrosis. You very well know the list of diseases associated with fibrinoid necrosis. I am not getting into that. Next, again a good slide. Question 50 and an important potential question. Diagnosis. 50. Which cell is this? This is a neutrophil showing the presence of very large granules. What is synonym for large? Giant. Giant granules, showing giant granules in neutrophils. Seen in which disease of innate immunity? I am still waiting for the right answer. I did not. Shinya-Higashi. Finally, 4448, you are the first one right. This is not the toxic granules. These are the giant granules. Toxic granules, they will be much smaller and much more in number. That is, toxic granules are seen in infections. These are the giant granules. Shinya-Higashi syndrome. This is defective phagolysosome formation. That is, phagocytosis is taking place, but it is not able to bind with the lysosome. Defective phagolysosome, Shinya-Higashi. Next, diagnosis. This came in this year's All India paper. You have a cell which has engulfed a neutrophil. So this is emperipolysis. Emperipolysis, it is the presence of an intact cell. It is presence of an intact cell within the cytoplasm. Presence of an intact cell within the cytoplasm of another cell. Within the cytoplasm of another cell. This is called as emperipolysis. Neutrophil is getting engulfed in this cell. Emperipolysis. Next, diagnosis. Nahi bache, this was not a band cell. I just saw this band cell, band neutrophil or a band cell will not be this large. This is a neutrophil which is present inside another cell. So it is emperipolysis. Next, question number 52. Diagnosis. Question 52. No, it is not liquefactive necrosis. No, it is a granuloma. What you have here is the presence of a giant cell with multiple nuclei in which the nuclei are arranged at periphery, showing granuloma formation. This is a granuloma with caseous necrosis, TB, most probably tuberculosis. This is not a Tauton giant cell bache. Tauton giant cell shows foamy cytoplasm. This is a giant cell, Langerhans giant cell. The nuclei are arranged at periphery, giving it the horseshoe shaped appearance with caseous necrosis in the center. That is TB, tuberculosis. Next, question 53. Diagnosis. Now I guess this is a spotter. ABCD. No, this is not Wardenfinkel day. No, not Tauton at all. Nahi bache. C. This is a tumor giant cell. This is a tumor giant cell. Unfortunately, in this PPT, I do not have the soft copy of Tauton giant cell with me. Tumor giant cell. Tumor giant cell, the tumor cells in the periphery have joined together to form a tumor giant cell. So the nuclei of the tumor cells and those of the giant cells are similar. This is not a foreign body bache. Foreign body giant cell, you should be able to see the foreign body. Foreign body is either suture material or talc powder, and that foreign body is refractile under polarized light. Refractile matlab wo chamak kar nazar aati hai. This is not a foreign body giant cell. Here the nuclei at the periphery, at the background and of the giant cell are similar. It is a tumor giant cell. Next, again a good question. Question 54, an important future question. This is an LE cell. That is, it is a neutrophil. That has phagocytosed denatured nuclear material of another cell. Okay, I guess we had slight technical issue. So LE cell, this is a neutrophil that has phagocytosed, the denatured nuclear material, of another cell, This is called as an LE cell. This is an LE cell and is an important future question. This is seen in bache systemic lupus erythematosus. Question 54, that was which patient with autoimmune disease. SLE, systemic lupus erythematosus, shows the presence of LE cells because the cells are getting damaged. It is an autoimmune disease. Cells are getting damaged, so the neutrophil phagocytoses the nuclear material of another cell, LE cell. Next, question 55. Question 55 was showing you the patterns of immunofluorescence. I'll just show you all four. This is the homogeneous pattern, the whole cell is green, versus speckled. Immunofluorescence patterns of with ANA, we have seen that numerous times. Speckled, you are able to see the presence of large black areas in between. Speckled versus anticentromeric, where you have antibodies against individual centromeres, anti-centromeric, and this is the few discrete spots against RNA. Question was which disease, question 55, which disease? This is the anti-centromeric pattern. You are able to see the presence of antibodies against individual centromeres associated with systemic sclerosis, localized or diffuse, localized type, associated with systemic sclerosis, localized type, anti-centromeric pattern, localized type. Next, question 56, question 56, diagnosis. Now the minute we see this, what is the parent organ? Suppose you do not know the parent organ. Diagnosis, this looks like a glomerulus, so if I am telling you that this is from the CNS, this is glomeruloid body, seen in glioblastoma multiforme, glomeruloid body seen in glioblastoma multiforme. So before we go further, glioblastoma multiforme, it's not schwannoma or meningioma, nahi bache. Glioblastoma multiforme microscopically shows us two features. First is large serpentine areas of necrosis, with peripheral palisading, of tumor cells. Matlab, there would be a large area of necrosis around which the tumor cells are present in a palisaded manner. The serpentine areas of necrosis with peripheral palisading of tumor cells. And the second is the the presence of glomeruloid body. So glioblastoma multiforme microscopically shows us two features. First was glomeruloid body, and the next is this, which is a large area of necrosis with peripheral palisading of tumor cells. Glioblastoma multiforme. This is an important slide. Next, diagnosis. Now what we see here are the neurofibrillary tangles. It is marked with an arrow also. What we see here is the presence of neurofibrillary tangles. These are hyperphosphorylated. Let me write it on the top. These are hyperphosphorylated tau proteins. Which looks like flames. Neurofibrillary tangle. See, this is looking like a flame. Look at this, it's a beautiful flame. Hyperphosphorylated tau proteins which looks like flames, seen in Alzheimer's disease. Next, 58, diagnosis. This is a spotter. This is a repeat question, has already been asked in the paper. Diagnosis. What you see here is the presence of rosette of cells. This is small round cells which are present in rosette like pattern. Rosette is round arrangement of cells with a central neuropil. Neuroblastoma. These are the Homer-Wright pseudorosettes. Why pseudo? True rosette should have a central lumen. Anything other than a central lumen is a pseudorosette. Neuroblastoma, Homer-Wright pseudorosettes. Next, diagnosis. What this shows you is, this is the abnormal affected area, this one and this one. Let us concentrate on the bigger one. It is showing a peripheral palisade of baseloid cells. The baseloid cells, they are present in a palisaded manner. So peripheral palisade of baseloid cells. Many of you are right. Peripheral palisade of baseloid cells with presence of slit like retraction. with presence of slit-like retraction. Diagnosis: basal cell carcinoma. Diagnosis: basal cell carcinoma. The tumor cells, they are present in a palisaded manner at the periphery with a slit-like retraction. Basal cell carcinoma. Next, this gets us to our last question. This gets us to our last one: cytogenetics. Agreed. Which this is karyotyping, chromosome 22 is affected. So, which T cell immune disease? Dye-George syndrome. Dye-George syndrome. I had 4-5 right answers the minute you saw this. Whenever a karyotype will be given, the affected chromosome will always be encircled. Do not worry, they will not just give you the karyotype and you will be asked to make a diagnosis. No, chromosome 22 deletion, Dye-George syndrome. Done. So this finishes the pathology session. In case you have any queries whatsoever, you can simply mail them to me at sushantsoni@gmail.com. My name is Sushant Soni. There is an extra S in between. You can send me a FB request on Sushant with a double T. I'm again stressing this. Done. And needless to say, bache, bestest of luck for the paper. Good luck and thank you.